You just bought 6 hospitals from the Archdiocese of Boston. The Catholic Church had been running these facilities for decades, serving some of the poorest communities in Massachusetts: Dorchester, Brockton, Fall River, Methuen. 600,000 patients a year, 12,000 employees, and a balance sheet deteriorating under the weight of pension obligations, aging infrastructure, and a financial crisis at the Archdiocese itself. You paid $246 million in cash. The total deal value, including debt and pension liabilities you agreed to assume, was closer to $895 million. But the cash out of pocket, $246 million. For that price, you got something almost no other business offers. A customer base with no alternatives. You cannot choose not to have a heart attack. You cannot comparison shop during a stroke. When the ambulance arrives, it goes to the nearest hospital, which, in these neighborhoods, is now yours. The government pays most of the bills. Medicare covers the elderly. Medicaid covers the poor. Neither program lets patients choose a different provider and take their reimbursement elsewhere. The revenue is not guaranteed, but the demand is as close to guaranteed as any business on earth gets. Ralph De La Torre stayed on as CEO. He was not a banker who wandered into healthcare. He was a cardiac surgeon trained at Duke, MIT, and Harvard Medical School. The youngest chief of cardiac surgery in the history of Beth Israel Deaconess Medical Center in Boston. He understood exactly what these hospitals were and what they could become. The plan was straightforward: improve operations, expand the system, turn a struggling nonprofit into a profitable network. Cerberus believed him. 6 hospitals, 600,000 patients, government as the primary payer, a physician CEO with a track record. What could possibly go wrong? A hospital is not a money machine. It is a margin machine, and the margins are thin. The average U.S. hospital operates on somewhere between 2 and 4%. Nonprofit hospitals, which make up the majority of facilities in the country, average closer to 1.7% in 2024, according to the Kaiser Family Foundation. On a hospital doing $500 million in annual revenue, a 2% margin is $10 million, before any unexpected costs, before any equipment failure, before any lawsuit, before any change in government reimbursement rates. Steward did not turn a profit in its first 4 years. From 2011 through 2014, Massachusetts Attorney General monitors tracked the system's finances closely, as required by the conditions of the original acquisition. By the end of fiscal year 2014, Steward's debt had grown from $326 million to $413 million. Total liabilities had reached $1.4 billion. This was not a scandal. It was a structural problem that every hospital operator faces. Labor is the largest line item, typically 50 to 60% of a hospital's total expenses. Nurses, physicians, technicians, administrators, security, maintenance. Staffing requirements are not discretionary. They are set by patient volume, regulatory minimums, and accreditation standards. You cannot reduce nursing ratios below a floor without losing your certification and your government reimbursement. Equipment never stops needing replacement. An MRI machine costs $1 to $3 million and has a useful life of 10 to 15 years. A Connecticut scanner, a catheterization lab, a dialysis unit. Each piece of equipment requires maintenance contracts, trained operators, and eventual replacement. None of it stops being necessary because your margin is thin. Cerberus was not taking money out. For the first 6 years of ownership, the firm reinvested all cash flow back into the system. No dividends, no management fees extracted. By 2015, nearly $900 million had been invested in hospital upgrades, new equipment, and expanded facilities, and still the debt climbed. There was, however, one thing Steward had that most struggling businesses don't: real estate. 6 hospitals worth of land and buildings, sitting on the balance sheet, assessed at hundreds of millions of dollars. Cerberus had an idea. In the fall of 2016, Steward Health Care sold its hospitals. Not the operating licenses, not the patient contracts, not the staff, the buildings, the land, the physical real estate the hospital sat on. Medical Properties Trust, a real estate investment trust based in Alabama that specialized in hospital properties, bought the land and buildings of Steward's hospitals for $1.25 billion. Steward immediately leased them back. On the day the deal closed, nothing visible changed. The same nurses were at the same nursing stations in the same buildings treating the same patients. The only difference was the name on the deed, and Steward had $1.25 billion in cash. A sale-leaseback is not complicated. A homeowner who needs liquidity might sell their house and rent it back from the buyer. Immediate cash, same roof over their head, ongoing rent obligation. Steward did the same thing at hospital scale. The transaction generated enough cash to pay off Cerberus's remaining investment, distribute $484 million in dividends to Cerberus's investors, and fund a major expansion. The following year, Steward acquired 18 hospitals from Steward Health Care, then more. By the end of the decade, the system had grown from 6 hospitals in 1 state to 36 hospitals in 10 states, the largest for-profit hospital system in the United States. MPT was not buying these properties at their assessed values. One Massachusetts hospital that had been assessed at $60 million went into the deal at $262.9 million, according to documents later filed in Steward's bankruptcy proceedings. The gap between assessed value and transaction price generated immediate liquidity for Steward. It also generated the lease payments Steward would owe indefinitely, calculated as a percentage of that inflated transaction price. Cerberus had entered with $246 million and a turnaround plan. 6 years later, it had distributed hundreds of millions to its investors, grown the system 5-fold, and positioned itself to exit. But now Steward had to pay rent every month on 36 hospitals to a landlord whose financial interests had nothing to do with whether those hospitals were good for patients or communities. And the rent was designed to go up. Between 2016 and 2022, Steward paid Medical Properties Trust approximately $1.2 billion in rent and mortgage interest. That is not the cumulative figure from the entire relationship. That is 6 years. The lease agreements included escalation clauses, rent that increased annually, regardless of whether Steward's revenue grew at the same pace. In the zero interest rate environment of 2016 to 2021, this was manageable. When the Federal Reserve raised rates aggressively beginning in 2022, the math became unforgiving. Hospital operating margins, already thin, compressed further. Your fixed rent obligation did not flex. Government reimbursement schedules did not accelerate to compensate. The payment that had seemed sustainable in 2016 had become, by 2023, something else entirely. Rosemary Batt, a professor at Cornell University who had studied Steward for more than a decade, described the structure plainly. Yes, other health systems are struggling, but not this badly, because other healthcare systems own their own property. They're not paying inflated rents that keep rising every year. By January 2024, Steward was $50 million behind on its rent payments to EMPT. From 2017 to 2020, Steward lost more than $800 million. After Cerberus exited in 2020, collecting its proceeds and transferring ownership to a physician management group led by De La Torre, the losses continued. The company was now servicing debt taken on to expand, paying rent on 36 hospitals, and trying to operate a healthcare system on margins that had never been able to support that overhead. In May 2024, Steward Health Care filed for bankruptcy, with roughly $9 billion in liabilities. The building is the same. The patients are the same. The rent never stopped. The rent never stopped. In 2021, Ralph De La Torre acquired a 190-foot yacht estimated to be worth $40 million. He also purchased a $15 million sport fishing boat. That same year, Steward's owners paid themselves millions in dividends. That same year, there were 95 patients in the emergency department at Good Samaritan Medical Center in Brockton, Massachusetts, and 11 nurses. By the time the bankruptcy filing arrived in May 2024, a pattern had been documented across Steward facilities in multiple states. Vendors had not been paid. Supplies had run short. Equipment had been repossessed. CBS News, which conducted a year-long investigation into Steward, found that a crucial medical device at one Massachusetts hospital had been repossessed by its manufacturer because of unpaid bills. According to CBS News' reporting, a woman died from internal bleeding that was not caught in time. A complication the device, had it been available, may have helped prevent. Audra Sprague, a nurse at Neshoba Valley Medical Center, testified before the Senate about performing an emergency intraosseous procedure with equipment that had degraded past the point of being reliable. The procedure requires drilling through bone. It felt like it was less mechanical, like you had to hand pump it to get this big bore needle to go through bone into a patient, she told the committee. Technically it worked, but it was ridiculously poor quality. Another nurse testified that staff had pooled their own money to purchase bereavement boxes from Amazon because the hospital would not provide them. 2 hospitals closed immediately after the bankruptcy filing. Kearney Hospital in Dorchester, which had served Boston's majority Black and Hispanic southern neighborhoods for more than a century. Neshoba Valley Medical Center in Ayer, which had served 17 communities across central Massachusetts. About 1,200 workers lost their jobs. Boston EMS, which had transported 6,000 patients a year to Kearney, had nowhere to send them. Steward's founder was not in Massachusetts when the hospitals closed. News reports placed De La Torre in Versailles, watching the Paris Olympics. In July 2024, the U.S. Senate Committee on Health, Education, Labor, and Pensions voted to subpoena Ralph De La Torre. It was the first subpoena that committee had issued since the Nixon administration. De La Torre declined to appear. In September, the full Senate voted to hold him in contempt of Congress. The Wall Street Journal estimated De La Torre's personal fortune at more than $250 million, accumulated while Steward was losing money year after year. Ralph De La Torre is not a banker who wandered into healthcare. He trained at Duke, MIT, and Harvard Medical School. He became the youngest chief of cardiac surgery in the history of Beth Israel Deaconess Medical Center. He built a reputation as one of the most skilled cardiac surgeons in Boston before he ever ran a hospital. He knows what happens when a hospital cannot maintain its equipment. He knows what a 95-11 patient-to-nurse ratio in an emergency department means for the people in those beds. He built the system anyway. Here is the scenario math. Cerberus Capital entered with $246 million in cash in 2010 and exited in 2020. Massachusetts lawmakers and Bloomberg estimated its profit at approximately $800 million, roughly 3.3 times its investment over 10 years. Cerberus's position: it saved a failing system, invested nearly $900 million in infrastructure, and operated at financial risk for a decade. No one at Cerberus was held in contempt of Congress. Medical Properties Trust entered in 2016 and collected approximately $1.2 billion in rent and mortgage interest from Steward through 2022. When Steward went bankrupt, MPT was drawn into the proceedings and agreed to cede $385 million in proceeds from a Florida hospital sale as part of the resolution. It was not a clean exit, but MPT model. Own the real estate, lease it back, collect the rent, generated real revenue for years before the structure collapsed. The communities of Dorchester and Ayr lost their hospitals. 150,000 patients lost access to facilities that had served their neighborhoods for generations. Kearney Hospital had operated for more than a century. The workers who staffed those hospitals lost their jobs. Senator Ed Markey, at the Senate hearing, named patients who had died at Steward facilities. Steward Health Care is not an exception, he said. It is an example of how private equity and real estate investment trusts treat hospitals as their own personal piggy banks. California and Oregon passed laws in 2025 restricting private equity transactions in healthcare. Other states are considering similar legislation. None of those laws reach back to Steward. The structures that made Steward possible: the sale-leaseback, the leveraged acquisition, the dividend recapitalization, are not illegal. They are the standard toolkit of private equity applied to an institution that its communities cannot replace. You did not buy a hospital. You bought the community's last line of defense against the worst days of their lives, and you used its real estate to fund an empire, leaving them with a rent obligation and a closed door. That is not unusual. That is how this works. Tell me, if you knew this is how the economics operated, would you still want to own the hospital? Or would you rather be MP and just own the building? Tell me below. If the institution you thought was protected turned out to be a balance sheet in a suit, there is a lot more of that coming. Subscribe, and we will keep going.